Welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
The team at the Research Works podcast acknowledges the traditional custodians of the land and waters on which we live and work. We pay our respects to all First Nations peoples, elders past and present, and would like to acknowledge the traditional custodians of the land on which we record this podcast each week, the Whadjuk people of the Noongar Nation. We recognise their continued connection to this beautiful budja we call home.
Well, hello everyone. I'm so glad that you can join us back on the show of the Research Works podcast. We've had a few weeks of a break and I hope that was really helpful for you to be able to catch up on some of the episodes that we've had previously. But what a way to start. We have a very special guest today. We actually have two very special guests today. We actually do have the lovely Marissa Smith joining us on the panel again today. Welcome, Marissa.
Thanks for having me back, Dana. You know I love being part of this. Last time I was with you, I was trying to remember what it was. We spoke to Anna from Cerebral Palsy Alliance.
Yes, that's right.
And today I'm so excited that we have another amazing researcher from Cerebral Palsy Alliance, Dr. Kathy Morgan. So welcome, Kathy.
Oh, hi guys. Thank you so much for having me. I'm excited to be here.
Oh, we're so excited to have you as well. We've actually been trying to tee this up for a little while. We all have very busy schedules, we know, but what we're going to be discussing today, you know, the paper that we're going to discuss is something that's really influenced my practice already, and I'm so excited to be able to tease out some of the beautiful pearls of wisdom from this. So the paper that we'll be discussing is titled Early Intervention for Children aged 0 to 2 years with or at high risk of cerebral palsy. It's an international clinical practice guideline based on systematic reviews, and it was published in JAMA Pediatrics in 2021.
This paper, I loved it, Kathy. Absolutely loved it. Now, this paper represents a significant piece of work that was completed by incredible world-leading researchers. In fact, when I looked at the list of authors in this study, it's a really long list. And I'm sure everyone, when they read it, will know a fair few of those names. And it's quite amazing that they're from so many places across the world. That just shows you the depth of collaboration, which is really quite remarkable.
I know. What a list, Kathy. My goodness.
Yeah, it was absolutely a pleasure to meet them all. And we did actually have an initial 2-day summit where we all got together in the same room.
Oh, wow.
That was some time ago. And so I think that meeting really drove the development of both the guidelines. So the early diagnosis one and this one as well. So it was, really great to collaborate with such knowledgeable people.
Yeah, that's why this paper is so incredible and so applicable. But before we get into all the details about the paper, Marissa, I'll hand this over to you. I know I always give Ash the hardest job in terms of reading bios because they often have a lot of really big words in them. But I'm going to hand that to you this time around.
It's all right. I practice.
Right.
Kathy, your bio is quite incredible.
Yeah.
So let me tell everyone a little bit about you. Kathy is a physiotherapist with a PhD in biomedical science with more than 30 years clinical and research experience in the field of cerebral palsy. Kathy is a senior research fellow at the Cerebral Palsy Alliance Research Institute and the University of Sydney. Kathy is part of an internationally recognised team of researchers conducting clinical trials of novel interventions geared to preventing, curing and treating cerebral palsy, the early diagnosis of cerebral palsy, and knowledge translation across the pipeline from bench to bedside to policy. Kathy has led the establishment of the first Australian early diagnostic clinic for cerebral palsy in the western suburbs of Sydney through a collaboration with the Children's Hospital at Westmead and the Cerebral Palsy Alliance. As you can tell from what I've just said, Kathy, this is incredible. And I love how you liaise with so many different people, and it's all about collaboration so that you can therefore have the biggest impact on the most amount of children and families. And I think, this is incredible.
It is so cool, Kathy. It really is. And I think it just it reinforces why, you can't do research on your own. You can't have that kind of impact, and it's all about teams. So look, we'll get into all of that in a little bit, but we're going to have to go for our icebreaker. So without Ash here, Marissa, you've got the icebreaker for us today. Are you ready?
I'm ready.
Okay.
Okay, Kathy, what was your first car?
Well, this is a really funny question because I use Mum and Dad's car. most of the time when I was a student.
Yes.
And then, then I met my now husband in my uni days, and he didn't have a car or a license. So, but he was the one with the money, so he got the car, and then I helped him get the license. So that was a good arrangement. But he had a little orange Datsun.
Oh,
it was a really
Datsun.
Shady little car. Yeah, we don't even know what Datsuns are anymore.
They probably don't. I've not seen them for a long time.
The air conditioning was wind down the windows.
Yeah. Oh, I relate to that one so well, Kathy. My first car was this beast of a car. It was like a Mazda 6, I guess is the number it gave. It was a 1981, so it was like a tank. It had no airbags, of course, because every car would just bounce off this tank of a car. And it had a choker, does anyone know what a choker? You had to pull it out, you had to pump the fuel, and that way you could then start the car. But if you pumped it too many times, you'd flood the engine, you'd be stuck there for a few minutes. And yes, no air conditioning. It was just wind down the windows, tank. Oh, and no power steering. Does anyone know how to drive without power steering these days? Oh my goodness. That was like trying to reverse park was nearly impossible. It was like an upper limb workout. So it's probably similar to the Datsun, but not as cool as the orange colour one. At least you can see you coming a mile away, Kathy.
That's true, and probably a good thing for the people around us.
I like that one. All right, Marissa, what about yours?
Look, the perks of having older brothers, much older brothers, is that their friends were ready to sell off their cars at this stage. So I conveniently got a 95 Mazda 323, which it's quite boxy, had wind-down windows, but look, no complaints. It got me to uni.
That's pretty good.
It was quite a trek, but it was very reliable.
And 95, that's like pretty modern.
It was quite new for the time.
Yeah. That's very impressive. All right. Well, I think it's always good to have good stories for your first car, and it's also good to be able to move on and appreciate all the new things in life, like this thing called Bluetooth, which is amazing.
I still don't have Bluetooth. One day.
I've got Bluetooth.
Nice one. I do like that. It's like a marvel, isn't it? Just to get in there and your phone connects and you can listen to music, and it's brilliant.
Yeah. You can kind of work while you're in the car.
You can, awesome. Yeah. How many meetings do you have when you're in the car? It's brilliant.
Quite a few, actually. I can listen to quite a few good podcasts too, as it turns out.
Oh, that's indeed true. This is a wonderful segue in terms of how brilliant the podcast is. So thank you, Kathy. Thank you. All right, well, let's get into the real stuff. There's so much to talk about here. So let me give you a bit of a rundown with regards to what this paper entails. So the aim of this systematic review was to evaluate the best available evidence about early interventions for cerebral palsy across 9 domains that promote motor function, cognitive skills, communication, eating and drinking, vision, sleep, managing muscle tone, musculoskeletal health, and parental support. The literature was searched for the best available evidence for intervention for children aged between 0 and 2 years at high risk or with cerebral palsy. Now, systematic reviews and randomised controlled trials were appraised by a measurement tool to assess systematic reviews called the AMSTAR, or the Cochrane Risk of Bias tools, with recommendations being formed using the GRADE framework and reported according to the Appraisal of Guidelines Research and Evaluation Instrument. This systematic review summarises 3 best practice principles with 28 recommendations specific to the 9 domains, and concludes that when a child meets the criteria of high-risk cerebral palsy, intervention should start as soon as possible to build on a critical development time for plasticity of developing systems. Oh, it's a good one. Excited.
I know, I'm excited to get into it. Before we jump right into it, Kathy, I wanted to talk a little bit about cerebral palsy first. And can you share with our listeners about the statistics on cerebral palsy and some of the types?
Yes, sure. So cerebral palsy is the most common physical disability of childhood. Mm-hmm. In Australia, we know about 1 in 700 babies now will be born with cerebral palsy, but the incidence can vary across the world. And we do know it's higher in low and middle income countries than it is in high income countries, for example.
Yeah, sure.
When it comes to types, there are sort of 4 main types. I guess cerebral palsy that's characterised by spasticity is probably the most predominant type, where over 90 to 94% of people with cerebral palsy will have spasticity as their primary form.
Yep.
A smaller percentage, about 4%, will have a dyskinetic form of cerebral palsy, and that can be athetosis, or it can be dystonia.
Yes.
And then a really small percentage have ataxic cerebral palsy, and then another small percentage have hypotonia, which is characterised by just low tone all around the body. But in some countries, hypotonic CP is not regarded as a category. So
Sure.
in Australia, we do regard it as a category.
Yeah.
But of course, it's really important to say that nearly all people with cerebral palsy will have some kind of mixed type. So they might be predominantly having spasticity, but also have some dystonia, or predominantly dystonia with some spasticity. So mixed is very important to understand as well, and it's quite common.
Yeah. And I feel like that part, we're increasingly recognising that clinically now. I think, even when I first started as a physio, I think we'd be kind of just be saying they've got spasticity or they've got this, and then you kind of go, hang on, there's a bit of both. And it's important to be able to identify both, because your treatments will be dependent on that, particularly medical treatments. So yeah, thanks for that rundown on that.
Now, next thing, Kathy, can you talk through a little bit, how is a child classified as being at high risk of CP?
Yes, that's actually a very important question, because we've used these terms just high risk for a long time, and they can refer to babies who are born very preterm. And we know that babies who are born preterm are all at high risk of some sort of neurodevelopmental outcome that isn't, typical.
Yeah.
But when we say high risk of cerebral palsy, we really are referring to the earlier guideline published in 2017, which highlighted that there are a few items that come together to give us this high risk designation, and they can be motor dysfunction plus either abnormal neuroimaging or a clinical history that's indicative of cerebral palsy. So when two of those things come together, we would say high risk of cerebral palsy. And it sometimes is just used as an interim while we're waiting for more information.
Sure.
And sometimes it's because we're hesitant to share a firm diagnosis with a family. We want to wait and see what kind of cerebral palsy a child will have. So it really is more specific than high risk generally, which can refer to anyone who's had a tricky start to life.
Yeah.
So high risk for CP has got specific parameters around it according to that guideline.
Yeah. And I think that's really worthwhile clarifying, because you're right, Kathy. Like, I think for so long, the term high risk CP, is something that we're quite familiar with, but this is now very much more formalised, and all these things that we're about to talk about relate to this group of children as well. Yeah.
Yeah.
Okay, so to also set the scene now, so now that we've set the scene with regards to high risk cerebral palsy and cerebral palsy itself, let's talk about what was included in this systematic review, because I think it's worthwhile laying the foundation of this as we go into the recommendations. So, Kathy, I know it's a really big piece of work, and so people can read about this in the article, but I guess just wanted to go through what was included within this systematic review. What kind of papers did you put into this?
Yeah, so we started off by wanting to find the highest level of evidence available across these domain areas.
Great.
So when the group initially got together, we discussed what the domain areas of interest would be, because they're the things that can impact on babies at high risk of cerebral palsy the most. So we had this long discussion together, and we came up with these 9 domains.
Yep.
So first of all, we looked for systematic reviews that were available in the target population.
Sure.
So 0 to 2 with CP or high risk of CP. If we couldn't find a systematic review, we then went to look at randomised controlled trials across each domain.
Yes.
And if we couldn't find any of those, we then went to the highest level of evidence that was available in the target population.
Ah, that's brilliant.
However, we got to a point with some of the different areas where there wasn't anything on CP specifically in the 0 to 2. And so at that point, we tended to look at other neurodisabilities. So when there was a mixed population, for example, including some CP, or older children with CP. So the actual paper does have an algorithm which is color-coded, so you can know where the data came from. So some of it is definitely from our target population, and some of it sort of had to be interpolated from other information that was best practice out there in the literature.
Wow, that's so good. So it really does go through this hierarchy of evidence, and it really does cover a broad range. So even if you didn't find anything in cerebral palsy, I love how you were still able to look further. So because you still want to be informed, don't you, about what's the best level of evidence. I love that. That is so unique. Now with regards to grade, now we're quite familiar with grades. I know it's a methodology that we've seen a lot through the papers we've discussed already, but I thought it'd be good on top of our knowledge about that, about how we actually classified the recommendations, or the 4-part continuum of recommendations. Can you go through what they are and what they mean? And then we can go through the actual, results of it from there.
Yeah. So I think the first part, just to recognise in grade, is the first thing you do is look at the quality of the evidence. So,
wonderful.
Is it high quality, like really good RCTs all pointing in the same direction?
Yes.
But then we get down to the recommendation piece. We start talking about how strong is our recommendation.
Yep.
And so we can have strong for a particular intervention.
Sure.
We can have strong against. We can have weak or conditional for, or weak or conditional against. And really, the deciding on those uses an evidence of decision framework. And in that process, the group of authors go through for each intervention the strength of the evidence in terms of how good the quality is, but also what are the resource use? What is the cost benefit? What is the risk of not doing anything versus providing this particular intervention? And those things are all brought together and discussed in a kind of iterative process. And so at the end of that process, you come up with a recommendation either being strong or weak or conditional. So weak and conditional mean the same thing, basically. Some people don't like the word weak, we've used conditional. But what it really means, clinically, is that we don't have as much certainty about this recommendation. For a variety of reasons. And so if we're going to say something is conditional, then we have to make sure that we discuss options with families and things like that.
Yeah, no, that's really, really good.
I love how you touched on as well that you sat down with this panel from across the world, because then we know that we've really got, you just classified that you worked out the domains together. Can you tell me a little bit more about what was the role of that big team and authors, and what was it like coming together with people with so much experience from all around the world?
Well, I thought it was quite amazing. It was some time ago. I mean, it took a long time to get these guidelines to life. The meeting was back in 2014, would you believe?
Wow.
And so we had this 2-day meeting, and then on the basis of that, a lot of us went away and wrote systematic reviews, actually, because we recognised at that meeting there was so little available in the field. So some of those systematic reviews informed this this guideline when we finally got it published. So pretty much we divided into some groups. We had smaller groups amongst those authors working on particular topics, and they would we extracted the data, looked at it together, and then when everybody's data came in, we put it in the one big document, and then we had must have been 5 or 6 rounds, mostly via email. I had occasional meetings with Professor Fetters in the US, and we sat down and went through where we were up to, and then actually this is inconsistent. We need to go back to the group about that. And it was just a long time, but really, really helpful process. And people had really great comments to make, and looking at it through different lenses is so important. So what does a neurologist think about what we've just written? What does a speech pathologist think about somebody's recommendation about eating and drinking? So, and also families. So we had people with a lived experience of cerebral palsy on the panel who read the whole document. We had policymakers who read the whole document, and we had clinicians and researchers across allied health and medicine. So I think it was pretty comprehensive, and everybody had an important part to play.
Yeah, it's so representative. I love that. In terms of applicability, what that means. But I can only imagine how much work it was to pull it all together. And I really encourage everyone to have a look at the paper. We're not going to be able to talk about everything in it, but the fact that the team have been able to present the work in the tables and in the figures in such a way that it's so easy to take away that information just shows the skill in this team to be able to do that. Don't you think, Kathy? Like to be able to take a lot of information and to put it in a way that's really easy digestible takes a lot of skill. So as lead author, you would have had to have led a lot of that, but the fact that you worked with a team that way is, hats off, because that's a huge feat.
I think so. Thanks for that. I also need to acknowledge Professor Ina Novak, who was amazing at visualising information. And so she had a really big role to play in this publication, as well as Linda Fetters.
Yeah, it's amazing. All right, well, let's get into the nuts and bolts of all of this now. So I thought we'd start with talking about the motor. Now, we know that there was a strong for early intervention, task-specific training. So look, Kathy, I'm just going to let you run with it when we talk about motor, because I think there's lots to say here with regards to what the recommendations were.
Yeah, absolutely. So I think the good thing about the motor section was where we had a lot of evidence, actually, or the most evidence. And it was also very informed, not just by randomised control trial evidence in the target population, but also similar results in older children with cerebral palsy or in other neurodevelopmental issues, or in stroke or TBI, for example.
Wow.
So the same kind of themes do come up across motor intervention across these groups. So that kind of helps you go from maybe moderate level of evidence to a strong recommendation because you're getting the same message across multiple disability groups. So I think that was helpful. This idea of starting early, I think, mostly comes from what we know about neuroplasticity. We don't have lots of randomised trials yet about young babies and starting so early, but we do know from a neuroscience point of view that starting intervention close to the time of an injury is really important for optimising neuroplasticity. We know that this window of 0 to 2, there's so many new connections forming in the infant brain, and experience-dependent plasticity is kind of the thing we're trying to harness. So that was the first recommendation, starting straight away. And then the next one was really about task-specific motor training. And, you know, you and I, Dana, have had a lot of conversations about this over time because I think it can be bandied around as a word that everybody adheres to, but not always quite sure what we're talking about. So I think it's important to understand that task-specific really is about repetitive practice of a task specific for the intended outcome. So if we just take an example to make it easy, sitting. If you want to learn to sit independently on the floor to play, and let's face it, that's the place where children start to learn and play and grow and explore. We need to practice sitting on the floor.
Absolutely.
You know, if we, I know that sounds obvious, but you know, sitting in a chair is actually not the same thing.
That's right.
So if we want to practice learning to sit in a chair, then let's practice learning to sit in a chair. If we want to practice learning to sit on the floor, let's practice learning to sit on the floor. And so that's really as simple as task specific. You get what you practice. So things where you're doing sort of, I don't know, practicing automatic reactions, for example, sitting on a ball by rocking the ball back and forth, that is not task specific. Because even though you might be thinking we're trying to teach the child how to react to their weight shifting to a side, which is something you have to learn in sitting. Doing it on a ball is not something you're going to have to do the rest of your life unless you go to Pilates, right?
Wonderful. That's true.
So I feel like task-specific training is so important, and it needs to be done in a playful way when we're talking about children. And so we practice things specific to the goals or to the intended outcome. And the same could be said for standing. If we put children in equipment all the time, they don't get a chance to practice their balance and to practice their weight shift and to use their muscles in the same way. So task-specific training is a really, really important one.
Can I say on that task-specific part again, you know how you said it was a great example actually, sitting on a ball versus sitting on the floor and actually doing the task of sitting. When you break it down, like I had a conversation with Sarah Reedman and Leanne Seksushki just last week or last few weeks now about what it looks like when you do like a part task practice and how part can it be for it to be still task specific. Now, when we're talking about this population, there's been so much in, just general talk about, you talked about postural reactions, for example, in terms of what it is. If you want to work on sitting, we often go to, we want better head control and we want better trunk control. And so we'll break it down and we'll just work on trunk control or head control. Can you talk me through why that isn't necessarily task specific, even though you go, to sit, you need head control and you need trunk control?
Yes, well, the task of to be able to sit requires you to be able to hold your head up to see things and do things. And it also requires you to protect yourself from falling over. So you can practice, I guess, sitting on a ball and your head would be bobbing around as the ball is moving. But really what you need to be able to learn is to hold your head up on a stable base so that you can interact with a person or an object. That's what head control is for.
That's right.
And so, I guess you could practice head control on, in a context where you need it on your mum's lap, for example. And that would be different to sitting because you might want to, depending on where the kid's up to, you might want to support the trunk more while they're practicing looking at a book or interacting with someone. But that's the task of looking. Which requires head control.
Great.
So I think if the child can do the pieces of the task together or has got some ability to do that, you want to try to set up for whole task practice because I think motor learning literature tells us that whole task practice is usually better, but we can't always do that. Sometimes you need half task practice or part task practice. But the important thing about that is you move it back into whole task practice.
Yes.
You practice the part of the task for a while,
Yes.
and then you go back into the whole task that you're trying to achieve.
Yeah, sure. All right. Sorry, I know I interrupted your train of thought there, but I thought it was just really worthwhile going through that, because I think sometimes we break it right down to those bits, and you actually need to practice the task, which is sitting. And I love how you related every single thing to what the actual task is. Then, if you're wanting head control in mum's lap, that's task specific practice as well. Yeah.
I think it's good sometimes to look too from the infant's point of view. What are they trying to do? They're trying to engage in the world.
Yeah.
They're not trying to get head control.
Yeah,
you know what I mean?
That's right.
We know that they need head control in order to interact with the world. So we try to set up their environment so that they can practice their head control.
Yeah.
Okay, so then there were two more recommendations. One was around constraint or bimanual therapy.
Yes.
And I think this is really important because it's sort of with unilateral cerebral palsy or suspected hemiplegia, there's been a bit of caution, I think, in the past that maybe we're not going to do them a service by constraining their non-affected limb too early, because what if we make their future hand function more difficult? So some of the trials that we included in this review or in this guideline really showed that that constraint didn't seem to do that. So we don't have evidence that it's going to make a massive negative impact at all. So, but it's important to say that we don't have enough information yet that we pick constraint over bimanual.
Sure. Okay.
So one of the studies was constraint versus massage. And another one was constraint versus bimanual.
Right.
The constraint versus bimanual showed an equal response, which it does in older children with CP, so not so surprising.
Okay.
And then the one on younger babies really showed compared constraint with massage.
Right. Okay.
And so constraint led to better upper limb unimanual outcomes than massage. So we've got nice evidence there, and we recommended 30 to 60 minutes just because those papers that's the level of therapy that they had. So it was like every day at home, 30 to 60 minutes, depending on the age of the child.
Which is so achievable, isn't it? It's really nice to have those recommendations. It's so brilliant. Yeah.
Yeah, and I think they also showed that parents can make it happen that's
right.
at home.
It's really empowering.
Absolutely. And there's more studies come out since then, actually. So I think we can be quite confident about the role of constraint or bimanual. And the recommendation really is that you use a bunch of other things to decide whether to choose constraint or bimanual in a certain circumstance. And then the fourth one is really a strong against, and this was against sort of passive movement approaches to improve motor skills. And in that we mean passive range of motion. And we're also talking about NDT, particularly the earlier forms, which is so dependent on facilitation, where a therapist is using their own hands-on techniques to try to facilitate a normal movement pattern. The guideline and the panel together looked at the evidence for that and recommended, since there are other options with more effect,
better options,
let's recommend against this.
Yeah, that's right. Are there any other approaches that fit amongst that? I think we talk a whole lot about NDT and the more passive form of it, that was really described earlier. Are there other ones as well that sort of fall into that category that isn't necessarily named here, but it still falls under passive forms?
Yeah, I would say one of the big ones that falls under that is Voiter therapy, which really is very dependent on a practitioner providing pressure points in certain positions, hoping to lead to motor skill development. There's really very, very low evidence. There's case series, for example, and they don't particularly show an effect. So, Voiter would also fit into that.
Yeah, okay.
But I also think about things like, using a therapy time to do passive stretches of the lower limbs and, the nappy change idea, and we should always be doing 10, hip abductions every time we do a nappy changes. And I think we should really be focusing much more on infant active intervention approaches rather than things doing to the infant, try to get them to activate their own muscle groups and
No, I think that's really good. And I love how that links with everything else that's in the recommendations as well with regards to that active generated kind of movements. Hey?
And that's what I found really interesting when I read the section of the cognitive domain. Yeah. We know as therapists, I know when I chat with families and assessments about goals, and it's always around, I'd love the child to be able to crawl so they can explore their environment and socialise with their peers or socialise with their friends. And what I love about this paper is how it links the cognitive and motor domains. And it seemed exactly what you said. It kind of aligns with motor in that the evidence was strong for cognitive intervention when it's active, self-initiated, it's self-generated, movements of real tasks with observable consequences, social interaction and multimodal learning. Yeah, I just love that because it's exactly like in the motor section. It has to be active for the child for them to have that cognitive advance. And the role that obviously motor plays in cognition is so important.
Yeah,
yeah, that's true. It's this concept of embodied cognition. There's quite a few papers around that. And really, as children use their cognition to solve a motor task problem. Yes. And it's a very interactive process.
Yes.
I think where it gets important when we've got children who can't explore their environment because their motor function is so low, but their cognitive skills might be more advanced. Yes. We need to bring the environment to them and bring opportunities to them so they can still act on their environment at the motor capacity that they have, and that enhances their cognitive learning as well. Yeah, so it was an important part of the guideline for sure.
Something I want to go on from that one that just occurred to me is, we often talk about, developmental milestones. And so once they do this, then they do that, then they do this. So, you learn typical development as a result of it. And that can give us a bit of a guide, but it can almost hinder what you might do next for a child who might have, say, more sort of, GMS level, so 3, 4, and 5 potentially, which they can't move and explore themselves as actively. Yet cognitively, we want them to continue to develop. So you almost do need to make sure that you're not strict on that sort of progression of one following the next. What would you say to that? Because I feel like that's often something we sort of really have to talk about.
Absolutely. I am not a big fan of the developmental skills milestone approach at all, although you're right. We have this as a bit of a framework about what typically occurs. But, I think that strictly speaking, that kind of approach might say, well, because most babies roll before they sit, we should wait till they've rolled before we start practicing sitting. Yeah. Or we need them to be moving on the floor before we practice standing. Yeah. Of course, in cerebral palsy, this is not a good idea because we want infants to activate their lower limbs as soon as possible. So specific activities that encourage lower limb muscle activation are really, really important. So I totally agree with you, Dana. I think we really need to be thinking about the future for these kids with cerebral palsy and what is it we can do now that will optimise their active use of their own body going forward.
Yep, that's right. No, I love that. And I think, if we find yourself as a therapist, you're talking to families, I think it's always trying to manage expectations because the families might not necessarily know that we don't follow that sort of framework of going, you must do this, then this, then this and that. We're actually talking about the child as a whole. We want to foster their own development. We're thinking about the future for them, and cognitive development is not something that I think comes up frequently as a specific goal that families might say. They might talk about motor first. What would your advice be there, Kathy? Because I think that we know that cognition is so important, but often isn't really part of our language early on.
Yeah, so it's interesting when you talk to families about that, and I think it's a good question to ask families because perhaps there's not a really clear understanding that everything is happening in parallel. It's not like you get your motor skills and then you get your cognitive skills and then you get your communication skills. It's actually all in parallel. Yeah. And so, you can be doing motor and cognitive practice within the same activity. It can also be social within the same activity. It could be language within the same activity. So I think it's really important to help parents understand that we're working on all of it at the same time. Yeah. But if you're early on in a motor skill, you might want to bring the cognitive demand down a little bit while they get better at the motor part of it. And then one of the ways you can make a task more challenging is to enhance the cognitive component of that task.
Yes, that's right.
While you might choose to start using technology early with kids who are really struggling because if they can use a switch and act on their world,
so good.
that's going to have great dividends for their cognitive development.
Yep. No, I love that.
I love how you talk about them working in parallel, and therefore as therapists, as a physio, we're not purely motor focused. We are including these cognitive strategies, and if we're working on sitting, then do we incorporate switching, and do we have toys that can help that promote active and self-initiated movements to also, develop their cognition as well. So I love that, and I think as therapists it's so important that we think broadly like that.
Yeah.
Now, I just love this quote regarding environmental enrichment.
Yep. And
it's, there are no risks for providing age-appropriate and skill-level-appropriate environmental enrichment and encouraging active learning.
It's such a good one.
Yeah. It's so true, isn't it? I mean, I was talking to a mum just yesterday actually about environmental enrichment. She said, well, it's not really an intervention, is it? It's like an approach or a strategy. It's like what we do all the time. And I went, it's true. But we do need to start thinking about it a little bit as therapists, because the environment that the child is learning in can have such a significant impact on how their practice occurs, for example, or, if they're chronically tired or their nutrition is down or they've got pain that hasn't been treated, all of these things can make the child so distressed and then the parent distressed that you can't actually get the motor practice that you want. So this enriched environment idea is sort of background for learning, but it's also enhancing, social, cognitive, motor, sensory experiences for the child, so that they really have access and to a variety of stimuli, I guess.
That links everything together, I feel. Like, already you can see it's so obvious now, motor and cognition, and you say environmental enrichment brings it together. The other one that really was connecting to that was vision. Can you talk to us a little bit about vision and how that fits in with all of this?
Yeah, so I think it's something like 70% of all children with cerebral palsy will have some kind of vision impairment. And I think it's 10% that have a severe vision impairment, right?
Yeah,
so, cerebral palsy is primarily movement and posture, but we know that there are multiple impairments that can coexist, and vision is one of those. And one of those ones that are really important, because if you don't have vision to drive your social interactions, to drive your reaching and grasping, for example, that can really have an effect, obviously, on the rate at which you're learning skills, and it can change interactions with people. So being able to understand whether a child has a vision impairment early on in the piece, it seems to be increasingly important, and it's an area where more research is currently going on to try to understand what are those strategies that we can use. So most of the information we've included here are from kind of low-level studies, but best available evidence to try to understand how important it is to start using visual stimuli in the environment, just high contrast, and attending to the vision specific needs of a child, and try to understand what those are as you're doing your intervention. Yeah.
And again, all things that you can do and implement yourselves quite early. You don't necessarily need a lot there. Like in terms of toys and equipment, what should therapists be looking for when it comes to that? What are some things they should have in their little rolly luggage bag as they go to homes?
That's a good question. Well, I think you want to have some objects that are sort of bright and shiny, because sometimes children who have got cerebral vision impairment respond better to those kinds of objects. I think a lamp, to be honest, or if you go to a home and a parent has got a lamp, you might want to make the room darker and just have a light that focuses on the toy you're trying to use or to encourage them. Having a black and white background can be really good as well. So you want to each child is individual when it comes to their vision need requirements. And I'm certainly not an expert in this area, but working in a sort of consistent pattern to try to understand what's working for the child is really important. And this is a stage where you might want to get in touch with people who are very vision experienced, I guess, and have a whole lot of strategies up their sleeve that you can also use in your session. So really important to not ignore it, actually, but to think about what is it that this child needs, and to be diligent in following up with strategies that are going to help the child maximise their vision in therapy.
That's great advice. And I love how that also then links to all things with regards to communication. Now, obviously I'm not a speech pathologist, but I work with amazing speech pathologists, and we think about that interdisciplinary model of what that looks like. Can you give us a bit of a rundown with what regards to communication that the recommendations came up with?
Yeah, so interestingly, we couldn't find a a review that was really specific to cerebral palsy.
Sure.
So we did find a couple of reviews that were kind of more broader neurological disabilities.
Yep.
And so we kind of used some of that evidence, which really focused on parent-infant interactions.
Sure.
And so this idea that you assist parents to understand how to set up an environment to encourage communication and to interact with their child. And so there's also a few programs like, I think it's the Mother-Infant Transaction Program, the Hannah It Takes Two to Talk program that have been used in other neurodisabilities with good effect, but haven't yet been specifically tested in cerebral palsy. So the recommendations are conditional here, but really are encouraging people to look at the strategies that work across the board in other high-risk groups and other children with neurodisabilities and to apply those.
Yeah. And I guess the principles of implementing that alongside the cognitive and the motor strategies are similar, aren't they? It's, you want them to initiate it. The principles remain similar, aren't they, Kathy?
Yeah. They are. And also things like interactive reading is another really important one. I think that we didn't highlight specifically in the guideline, but I think there's a lot of evidence out there in the general early intervention literature that you can build that kind of into the cognitive and motor things you're doing. You can be doing sitting practice and social interaction, joint attention, looking at a book together, and might feel like playing with a child, which it is, but it's also having these this opportunity for the child to be enjoying social interaction, getting a sense of communication, as well as learning to sit, as well as cognitively growing at the same time.
Oh, so I love all of that. That's really inspiring to think of how you can put all that together. It's very cool, isn't it, Marissa?
I love it. Love it. I get excited.
See a big smile on your face.
Now, very importantly, we've talked about the impact of sleep, and we know this impact of sleep on not only the child but the parents as well if they're getting interrupted sleep. Now, we know poor sleep means obviously the child is probably has more difficulty regulating in the day and is more irritable. So therefore, the information we have to support sleep is very important. And in your review, obviously you said there was strong evidence against stimulating activities before bedtime and watching TV screens and vigorous play. Now, often we're aware of these, and I think these are often informed in the media and told to parents from quite an early age.
Good point.
But can you talk me through some of the conditional against for sleep?
Yeah, so this was an interesting process because we looked at a couple of reviews or narrative reviews really rather than systematic reviews across other neurodisability types. And there were some things around complementary interventions such as osteopathy, acupuncture and things like that. And in the end, the panel decided that we would have a conditional against these things because we couldn't agree that the benefits would outweigh the possible harms.
Okay.
And so that was an interesting point to make. Some people really swear by these things, such as osteopathy, for example, but we couldn't recommend it in here because the risk of harm we thought was still present there. And so we think probably there are other options that are probably going to improve sleep more than those complementary interventions. But I wanted to point out that there will be some people who want to use those or try them because they're desperate. But I think as a panel, we didn't feel it was responsible for us to put a full recommendation on that. And I think sleep positioning systems is another one that's difficult because, children who've got severe cerebral palsy can't move on their own or correct their positions. But there's been incidences for people with cerebral palsy where sleep positioning systems have actually caused them harm and asphyxiation. So we were keen to not recommend those at this early age when the children couldn't get themselves out of position. So, there was a lot of debate and back and forward about those items, but I think we need to feel that we were being responsible with our recommendations in that space.
Absolutely. And before we move on further, you know how you mentioned about crying and things like if a child is crying and what that can produce elevated cortisol levels. Why is this harmful in this age group?
Yeah, because this stress response in a child is not good. It's actually bad for their neuroplasticity. It's bad for their emotional well-being and probably potentially could impact their attachment. So overall, we across the whole of the guideline, actually, we recommend that activities that you're doing with children in therapy should not produce crying. And in fact, it's your responsibility to say enough now. I mean, parents often will, but sometimes they think that you're doing you're the expert and but really
sure.
our role is not to stress babies out.
Yeah.
And so when our intervention is causing a baby to cry, then we're potentially causing harm, and we need to stop and think about, how do we need to change this up? Maybe it's a bad day.
Yeah.
Are there other things we need to think about around, is the child in pain?
Yeah.
What else is going on for this family? And so overall, there was unanimous agreement in this panel that we should be stopping interventions that produce crying.
Yeah. I think it's good to even talk about that, because I love how in your paper, let me just find the quote where I absolutely loved it, where you said, infants are trying to learn with suboptimal background of pain, low caloric fuel and irritability. And you often do see that in the under 2 years of age. And if they're crying and they're irritable, even if you're implementing an evidence-based intervention, if they're still crying, you need to try to find an alternative. You don't keep pushing forward. That's
Absolutely.
the main point, isn't it?
So, yes, it is the main point. And a child's well-being is paramount.
Yes. Yeah.
And their parent is in charge.
Yes. Yeah.
Parents don't like watching their children cry. And if we give them the impression that it's okay at therapy to cry, then it sort of goes against everything that they would try as a parent to try to keep their child settled and calm. Yeah. So, I just want to say at the same time that there are some children who really struggle with therapy, and they're unsettled through most of therapy. And I think it is our job to really work hard to try to understand why. Some of the things I might do is work much harder at coaching the parent to carry out the activities and be less sort of hands-on myself.
Sure.
And that's up to me then to develop my coaching skills better, and to kind of try to talk with the parent, help them to understand what else is going on for their baby. But it's a really important point. I think it's good to discuss it out loud.
Yeah, just not to keep pushing through. I think sometimes it's pushing through, and there are things you can do in your session. Obviously, people they will engage with the NDIS to pay for a service, and you might feel the pressure of finishing the session because they've paid for that service, but there are alternative things you can do, like coaching. And I love how you said that. So you can still use that time really meaningfully, really ethically, without causing harm to the child. And I think that's
exactly.
Yeah.
And sometimes it can be, okay, if you try this at home with your child, what happens? Do you get the same response?
Great.
And are they having a bad day today? Trying to really understand what's caused the child to be so upset.
Yeah, that's really good.
And I love how you said, it's important if the child is crying, not only is the child upset, but the stress that they may produce to the parent, because that's stressful for them themselves. And also if that's on top of possibly poor sleep and irritability in the day because there are difficulties with feeding or other issues, this is where we come down to mental health, which we know in the community is spoken about increasingly, which I think is very important.
Good point.
But can you talk to us a little bit about the conditional recommendations around mental health?
For parents, yes. So it's important to say that this is really about how do we support parents. And interestingly, we didn't find a lot that was CP specific. We found a few different RCTs where parent well-being had been monitored throughout the intervention, but hadn't been particularly acted upon. There wasn't part of the intervention that was devoted to the parent specifically or to the parent's emotional well-being. So what we did find out is if you don't attend to the parent's well-being, you can't expect their well-being to be okay. So, it's one thing to provide intervention for the child, and usually, most parents are desperately wanting as much help as they can possibly get to help their child learn. But sometimes they can put their own needs on the back burner, so to speak. And so it's really important that we think about parent well-being and how we can support parents in their role as parents. So the things that we ended up having recommendations for were really from other literature, so literature of other children, parents with older children with cerebral palsy or other high-risk groups. And there were conditional recommendations for cognitive behavioural therapy for parents who'd experienced trauma as a result of their child's birth story. And for those parents experiencing stress, anxiety and depression, just typical mental health therapies that are available for all people who are experiencing those conditions. We would recommend. And then there were specific ones in the NICU like music therapy and kangaroo care, which we know have a really good effect on parent bonding, reducing anxiety, but also do have an effect on child wellbeing as well. So there were those interventions that came up as important. And we can, from the literature, understand too that you can change train parents to be responsive and supportive, sensitive to their child.
Sure.
And so there are definitely interventions around that, and that also helps parent stress and anxiety.
Yeah. I love that you guys included this in the guidelines, because I think it's you can't expect the child to thrive if the parent is, already completely full. They're not sleeping, like you just said, Marissa. We need to look at that before you can move forward. Again, you don't just keep pushing forward with, the evidence-based practice principles. They're good, but you have to look after this too. That you can't see them in isolation, can you?
Yes, a parent and a child are, we call them the dyad. They interact with each other, and it's so important. And that relationship is primary.
Yeah.
And we need to look after it.
Yeah.
And that doesn't mean just looking after the child.
That's right. Yeah, I really like that. So last little thing I think to bring it all together is the best practice guidelines. So the principles, So there's 3 of them. And, again, I really encourage everyone to have a look at the tables and the charts. We can't go through all of them, but we've really tried to bring them all together for you now. But in terms of the best practice guidelines, Kathy, can you go through what they are and what we can do as clinicians?
Yeah, sure. And I think this is really important for all kinds of early intervention and intervention generally. And the first one was that we don't want to have a wait-and-see approach to starting early intervention.
Yep.
And so we had a chat at the beginning about what this high-risk designation means.
Yes.
And we think that, and the group agreed that it's enough to have a high-risk designation, not a confirmed diagnosis of CP, in order to start early intervention. And the closer you can do that to the timing of the injury and to the recognition that this child is high risk, the better. And that goes along with all neuroplasticity principles. And so parents do not actually want to wait and see.
Yeah.
They actually want to start and know that they've done everything. And so I think this was a really one that we all agreed on. You can also find this in the previous guideline. We want to get going straight away. The second one was that framing early intervention around goals is important. And these goals ought to be task specific, and we've talked about that at length today.
Yep.
But also involve coaching.
Yep.
But also that they're context specific. So, for example, it's not a goal for a child to learn to sit on the floor in your therapy room. It's a goal for them to learn to sit, and probably best in a room that they're going to spend most of their time, which would be home or daycare or grandma's or wherever they are through the day. So we haven't talked much about context specific, but it is really important because, walking on a hard floor is not the same as walking on carpet, which is not the same as walking on uneven ground outside.
That's right.
And so, we know as therapists that we need to grade that up. But, if we only practice in one sort of environment, we don't practice in another, or we don't have a goal around another environment, that can really get in the way.
Yeah.
So goals need to be task and context specific and sort of involve parent coaching. And they should be collaborative too. I think that's the other really important thing. So we sit down and talk to parents about what they think they would like to see or focus on in this next little epoch of time.
Yes.
And then the third one was building parental capacity and expertise, because most of us can't see kids more than about once a week in the organisations we belong to. The funding's just not there.
Yeah.
But really, children learn through their everyday experiences. They don't just learn from that 1 hour that they might have with us.
Of course.
Helping parents understand how they can help their child is incredibly empowering and important. And so setting up home practice in a way that's playful and fun and feasible for families is really important. And that's why working with a parent, like you're a partnership, you're a team, and you need to talk to the parent and ask them what's possible for them. There are some families who are just got lots of time because it's their first child and mum's taken a year off.
Sure.
And then there's other families where mum's had to go back to work after 6 weeks and she's got 3 other kids. So the situation is different for each family, and that's why it needs to be customised and collaborative and strengths-based. What is it the parents can do and work with them on that. So they were the overall principles. I think they were easy to agree on, to be honest.
Yeah, I bet they were. It just brings it all together though, doesn't it?
Kathy, I've done a lot of nodding. I know the listeners can't see me, but I've nodded throughout this podcast, obviously in agreement and just loving what you're saying. So we've covered so much, but where to from here?
Yeah, well, excitingly for me, I love this space. I love early intervention and thinking about how we can help families and children with cerebral palsy grow and learn. So it seems to have taken off. A lot of randomised controlled trials are currently underway around the world. And so I feel like we're going to have to do an update for this guideline in just a few years, because there's going to be so much more data available. So I think in a lot of ways, the guideline, when you see the areas where there was very little evidence, and let's face it, that, quite a few of the domains we didn't have heaps to work with, but we still wanted to make a recommendation because it's still important.
That's right.
I think we've got a lot of research work to do to try to understand how do we promote communication better. We don't have any randomised controlled trials in cerebral palsy 0 to 2 for communication.
Right.
That's terrible, in my opinion.
Yeah.
We don't really know which of the vision strategies we should be using and how.
Okay.
We need much more research across the board, cognition as well.
Yep.
Eating and drinking. There was only a few studies on feeding, for example, which we haven't touched on today, but, they were mostly about compensation and thickening foods and sitting kids up straight. But the stroke literature for motor learning feeding interventions was really strong.
Yeah, that's
so we need to work on that as well. So I think there's a bit of a blueprint there for more research is not needed, which I know we say after every guideline, but it is actually true. And my feeling is that because early diagnosis is relatively new, this field is gaining momentum quite quickly. And I think that's exciting. And I think we'll get more information. And our certainty about some of these recommendations may change, which is the point of conditional recommendation, right?
Yeah, absolutely.
So we know if we get more information, we're going to be more confident one way or the other.
That's great.
So I'm looking forward to seeing that.
Oh, that is exciting. I think, that's the whole point, isn't it? You move with the research, and research will direct our practice, and we just got to wait for more data as well. So that's the whole point. We're never the same. We're never static, and I do love that.
And I think it's so important as therapists, if we want to do the best thing we can for our clients that we work with, is to really try to stay as much as we can on top of what the evidence is telling us and seeing how we can feasibly implement that into our everyday practice.
Oh, that's like
brilliant.
The best quote. I think we're both nodding there. All right, well, we've gone through a fair bit there, but we're not quite done yet. Remember, everyone loves this next segment. They always say it's their favourite. So here we go. Tell it to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he has been listening. I even noticed him taking a few notes today. So this is going to be interesting. So, Kathy, I'll get to you in about a minute or so to summarise this body of research for Ed. And Ed, in turn, will have time for a question. All right, take it away, Kathy.
Okay. All right, here we go, Ed. The area of early intervention for infants with cerebral palsy is more important than ever because the age of diagnosis is coming down globally. Clinicians working with families want to know that most evidence-based interventions are available to apply. This guideline provides up-to-date information about therapies to improve motor skill development, cognitive, communication, eating and drinking skills, and also how to assist children who have got co-impairments such as vision problems, sleep problems, increased tone or musculoskeletal problems, and how to support parents.
That's a good summary for something that was so big. Well done, Kathy. That was really great. All right, Ed, over to you for a question.
I have to admit that's a rather impressive synopsis of a tremendous amount of work in the space of about 35 seconds. So
that's impressive.
I'm sure you've missed quite a lot of details there for me. But I think over the course of the last 56, 57 episodes, I've learned a lot about evidence-based practice and what that kind of means in pediatrics, and cerebral palsy has been a big part of that. Obviously, the previous episode we spoke with Dr. Riedman and Dr. Sakzewski, and then I think before that we had Anna Tvelda as well, and then very early on we had Iona Novak. And I think I've had a greater appreciation for the amount of work that it takes to keep up to date with the evidence, because it seems to be a very difficult thing to do for clinicians and practitioners. Obviously, in the world of social media, there's lots of commentaries and videos and all sorts of new and inventive kind of therapies that have kind of come along, and they kind of have to compete with obviously what researchers are trying to bring to the foreground, and oftentimes that's, by my understanding, a few years later than when they finished due to publications and all the rest of it. And I think I'm relating a lot of this work to like learning a language. And so where the best way to learn a language is to actively engage in it and kind of learn the phrases and learn how to say something with context and know like how to kind of put things together. And like I'm learning French at the moment. And I'm not picking up a French dictionary and learning like the 100,000 words in French. I'm learning how to put that together and in context. And like I can't travel around with a tour guide or a translator all the time. So I'm kind of appreciating the fact that there's a lot of active work that's involved. But I have to admit that at the end of all of that, I'm really surprised that therapies like the ones you mentioned, like the Voiter and Anna Teveld spoke about NDT, and then you have the CME, the Quavis Medic that I think we spoke about with Dr. Rubin and Sakzuski, and then their variation of that, the DMI, the dynamic movement intervention. They all seem to latch on to the idea of inactive therapies. And so my question at the end of a very long spiel, my apologies for that, is that a dangerous form of therapy, or is it just a form of therapy that isn't as effective as the active, engaged types of therapy?
Oh, that is a good question and pretty controversial. Thanks for that, Ed. Appreciate it. I think overall that people can be very confident about an intervention that they're delivering and asking people to pay for without a lot of background evidence behind it. That seems to be the way, not just in cerebral palsy, but across the board. People can be very confident without evidence and they just state things. I think what we're trying to do, what research is trying to say is when we actually rigorously test these interventions, this is what we get. And it's not a massive effect most of the time. It's a small effect and it's a cumulative effect over time. But I think it could be wasted opportunity for children, Okay. Babies are small and in this rapid period of development between 0 and 2, surely we want to draw on neuroscience and what we know works to give kids the best opportunity to learn something. All parents who choose these interventions want the best for their child. People are choosing things that or feeling desperate because they're not getting enough of something or things aren't working. I think what we really need to do is to change the field a bit so that these active evidence-based interventions are available at some sort of intensity that is going to work for parents. And that's the gap we've got at the moment. And so people want to fill the spare time they've got with something that's selling itself quite strongly. So I think we've got a real challenge on our hands to try to influence the system, if you like, to provide resources and opportunities for families to access evidence-based therapies at an intensity that they want.
Sure.
Oh, that was well put. That was really great. Yeah. Thank you, Kathy. I think it's always something that I guess is on people's minds, and I think we are just trying to do our best, and everyone's trying to do their best. And I love how you framed that as well. So, gosh, Ed, that was a big question, and well done on learning French.
I'm getting there.
Yeah, good luck with
Slowly
that.
but surely.
All right. Well, to all of our listeners, thank you so much for tuning into this. A big, big thank you to you, Kathy. Thank you for your time, sharing your expertise, and to go through this paper with us in such detail. Thank you so much.
Yeah, thanks, Kathy.
Oh, you're welcome. It's been fun.
Oh, we loved it. Absolutely loved it. So remember, you can head to the website, researchworks.net, if you want more information about the paper and links to Kathy and the work that she's doing. And remember, there's a CPD form that you can fill out there as well if you want to keep this a part of a record of your CPD. So for now, thank you very much, and we'll talk to you all again next time. Bye.
Bye.